just an overview. Let me know if you don't hear me. I don't know, sometimes my work computer gives me problems with the microphone, but we'll just go over the basics of COPD and just some, I think, important clinical points. And then I start off with a case of one of my own patients, but then as we go through, we'll do some cases that I pulled from Seek and tweaked a little bit with some questions. So, just to get you thinking, and just interrupt me if there's any questions at any time or something you want to bring up. So the basics, like I said, and we'll really talk a lot about, a proper diagnosis and workup when you see these patients in the office, typically, a lot of times also in the hospital, of course, when they're having exacerbations, and then maintenance therapy and monitoring them on the outside. And then other things, other therapies to be thinking about, pulmonary rehab, of course, lung cancer screening, and then other more invasive options for treatment of emphysema. So this is a patient of mine that I actually saw when I was one of my first patients as an attending, and he's this 58-year-old gentleman who has diabetes and hypertension, BMI of 43. He came in for initial evaluation of obstructive lung disease. His primary care doctor had been managing this for years, and had I'm not quite sure how this man was out, in without seeing a pulmonologist in so many years, and was just being managed on oxygen for so long. But he did have a significant smoking history. He had quit almost 20 years prior. He did report a significant World Trade Center exposure the first few days after. And says that he was diagnosed with COPD about 10 years prior, and hasn't seen anyone a pulmonologist in more than 5 years. He's maintained on Spiriva, Symbicort, ProAir, and uses Duonebt as well. He had been hospitalized a couple of times in the past year, treated for pneumonia each time, and was sent home with oxygen. So when I saw him, he became easily dyspneic, even just walking down the hallway to come into the exam room, and said, with half a block flatland, he can slowly complete a flight of stairs, but definitely had to stop at least a couple of times before he could complete them, and then at the top. And because of this, he's become less active and has gained 30 pounds over the past year. So next steps, for just to keep us moving forward, what do you want to do? Of course, you want to have him undergo some pulmonary function testing to see what his lung function is like, his DLCO, labs also. So he's 58 and was diagnosed at about, in his late 40s. So definitely you want to get a good family history and send alpha-1 antitrypsin levels. You also want to do chest imaging just to see, what the, if you see emphysema, of course, and or other findings. 6-minute walk test, especially in someone who's already on oxygen, is very symptomatic. You want to see how far they can walk. You want to see how much oxygen they need, and how symptomatic they are objectively. And then something to always keep in the back of your mind, and we'll talk about it, is also some sleep study of some sort. So whether it's a home test or in-laboratory test, and depending on what his labs look like, you might also consider transcutaneous CO2 monitoring, especially because he's obese and with the significant, what we're presuming is significant obstructive lung disease. So he had PFTs. I'm sorry, they didn't come up that clear. But what you can see is that he has, actually, his ratio is normal, but you do see that his FEV1 is mildly reduced. He does not have a significant bronchodilator response, but his vital capacity and total lung capacity are, I would say, borderline low. And what really stands out is his DLCO is severely reduced. And you can see, of course, his curve right there. So this is what I would think is a mixed restrictive and obstructive defect, and he's got severely reduced diffusing capacity. So probably, a degree of obstructive lung disease. Also, he's obese, like I said, but that DLCO was pretty low. And then this is a couple of slices from his CAT scan, and of course you could see the emphysema here. There was really nothing else on there. I didn't see any bronchiectasis or any fibrosis or anything like that. So in terms of his labs, CBC was, no erythrocytosis. He had normal bicarb. Alpha-1 was within normal, and his A1C was 10. I don't know why I sent that, but for some reason I did it. He walked 6 minutes, but had to stop. So he walked the entire time, but had to stop for a minute midway through. His total distance was 221 meters, and he required about 4 liters to maintain O2 sats above 90%. Echo was read as quote unquote normal, but they didn't get a good visualization of the RV, but it was grossly normal right-sided function. So at that time I said to him, okay, let's continue you on your triple therapy. Stay on your oxygen, of course. Weight loss, I think I referred him to the weight management program. Pulmonary rehab, which took a little while for him to get in, but he did end up enrolling and actually really benefited a lot from it, from a exercise tolerance standpoint, psychologically too. Before this, he was working and things had really progressed over the past few years. So for him, psychologically, he has, a young son and all that kind of thing. It was very difficult for him. And he did very well with pulmonary rehab, and he's still doing pretty well, considering. So a little bit of background, of course, this is basic, but just umbrella, COPD is an umbrella term for multiple causes that lead to airflow limitation that's not fully reversible as compared to asthma. It's a combination of chronic respiratory symptoms like wheezing, shortness of breath, cough. It can be productive, of course. And then also you can have structural pulmonary abnormalities, so airways, emphysema, both, and lung function impairment. So this is this was a curve that is famous, I would say. It comes up in a lot of papers. It's referenced from 1977, and it's the Fletcher-Peto curve that was the first to really graph out and talk about the natural history of COPD and how your FEV1 naturally decreases with age. So in never smokers or not susceptible to smoke, whatever that means, you could see what the curve kind of looks like here. Then here you see what it looks like if you smoked regularly and in quote unquote susceptible individuals. And then what the curve looks like when you stop at age 45 and how the steepness, of course, of the curve is less. And that's really what, when it was first described, and really this is what typically happens. You do regain, not that you regain, well, no, you can regain some lung function, but really the decline in your FEV1 starts to match a little bit more with what your age, matched non-smokers would look like. And as we know, COPD in general is very common, worldwide prevalence of 10%, third leading cause of death worldwide. But believe it or not, when I was reading some papers, they actually said that it's underdiagnosed in the primary care population. So, we see the patients that are referred to us, but in general, it's something that is even more prevalent than probably what's being reported. And of course, we know that smoking is a huge risk, and it was one of the first identified risks for COPD. And this goes back, actually, it goes way back, a couple of centuries back, that it was recognized as causing these symptoms. It's a bit more prevalent in males with smoking history, a little bit different if you look at the demographic of females who are non-smokers and have like biomass fuel exposure, and also outdoor pollution. And then this basically is just an overview of the pathogenesis. So you have some sort of irritant, most commonly cigarette smoke. It causes oxidative stress, and then you have typically a genetic predisposition too, which causes your macrophages to your alveolar macrophages to be activated, and then you start to recruit neutrophils and CD8 cells from the circulation, and then you activate fibroblasts, and it's this whole cascade that causes fibrosis, alveolar wall destruction in the form of emphysema, and then you have mucus hypersecretion, which causes chronic bronchitis. Okay, so really just an overview, and a lot of, I know I had sent out the link to the quick version of the GOLD criteria, but the website itself has a lot of information, and a lot of the slides actually come from there. They have teaching slides there, but it's good, you know, to kind of get an idea of what's out there, and this is one of them. So like I said, you know, smoking, pollutants, host factors, there's an interaction, and then there's an accelerated decline in function, recurrent lung injury, and systemic inflammation. And then it manifests as smaller, you know, airway disorders, emphysema, and other systemic effects. I'm not going to talk about, you know, cardiovascular disease and all that kind of stuff today, obviously, but just kind of, you know, there's a lot of systemic effects, of course, that we know. You develop persistent airflow limitation, and then the clinical manifestations, followed by exacerbations that make everything worse. So once again, this is kind of, you know, just an overview. This actually was a paper that was in New England Journal not too long ago by Biarcelli. I didn't send it out. I thought it was a really good overview, though, if anyone wants to take a look at it. It really breaks it down. And Biarcelli is actually one of the main people who writes the who established, you know, GOLD criteria. And if you ever get to see him lecture, he's actually very knowledgeable and very entertaining. So just, you know, as a little aside. But really, you know, you're looking at risk individuals, okay? And what you're going to do is obviously send them for spirometry, right? And if their FEV1 is less than, here they're saying 80% are predicted, then you're going to grade their severity. And we're going to talk about the updated GOLD grading guidelines that I know all the third years know you need to know for boards as well, but it's good to know how to grade your patients. The same way we grade heart failure, we should be grading COPD. And then as you evaluate them further, then you're going to do some dyspnea and symptom scoring scales, which we'll talk about. And then depending on where they fall within this, which is the updated grading, then you're going to, you know, decide how you're going to treat them. So if they are lower scores in terms of their symptoms and have not had recent exacerbations, then you're basically going to be treating their airflow obstruction with bronchodilators, short-acting and maybe long-acting. Then if they have higher scores, no exacerbations, then you're going to be closely be monitoring them. You're going to be giving them longer acting bronchodilators, right? And you're going to be considering pulmonary rehabilitation. And then as their scores go up even further and they, or not their scores, excuse me, they start to develop frequent exacerbations or even 1 or 2 exacerbations in the past year, then you want to be more aggressive with treating them with inhaled corticosteroids, other anti-inflammatories, and of course, this is, you know, all the other things we do. So just a brief overview. Okay, so we already talked about all this. I think what's important, other than what I already said, is this right here. So I've actually noticed this, and you know, it was something that I wasn't as aware of, I think, as a fellow. And then as I started to see more patients who were symptomatic but had normal spirometry, it was, you know, it kind of caught me off guard. I said, well, you know, how can I call this true COPD if you don't have some sort of obstructive dysfunction on your PFTs? But some of them were active smokers or, you know, were trying to quit. So I think the whole point is that it's like a pre-COPD type, and you want to follow them closely. You want to really get them to stop smoking, of course, and or eliminate other environmental contributors, whatever that may be. So it's just, these are like your pre-COPDers, and you want to really pay attention to them. And it doesn't mean you don't treat their symptoms, you know, with short-acting bronchodilators, but, you know, they're just really impressing upon them that they're at increased risk for persistent airflow limitation. The labs, like I talked about, is pretty self-explanatory. Of course, if they're having productive sputum, chronic bronchitis, then productive coughs, excuse me, then you want to send off a sputum culture and make sure they're not colonized with something that needs to be treated eventually. And of course, the CAT scan, we know about areas of low attenuation in emphysema. You look for bronchial wall thickening. Of course, you can, if you have small airway disease, then you can show evidence of mosaicism and air trapping. And the last thing is of course, lung cancer screening. If they're smokers and they have lung disease, then they're at higher risk, obviously, for lung cancer. So this all plays a role. So the CAT scan early on, I think, is definitely important, and you can make a good case for as part of your workup. So this is GOLD classification. So how it was traditionally done was based on FEV1 % predicted, and then you would classify them as 1 through 4. Now what they've done is they've updated it. I mean, it's not that recent, but still, regardless, it's been updated where you're also taking into effect what their symptoms are like. And so basically, you're still basing it on FEV1, 1 through 4, but then also how often are they having symptoms, and if they're high or low risk for exacerbations, hospitalizations. And then you put them into one of these categories. And we'll talk about this more. So again, from the GOLD criteria, this is really, this goes over it again, but basically the way you're going to use this square here to put them into a subcategory is by either your one of your dyspnea scales, which I'll go over them, or symptom scales, excuse me, and if they've had exacerbations and what their FEV1 looks like, % predicted. Okay, so this is the modified MRC dyspnea scale. Technically, every time we see someone with COPD, chronic lung disease, we should be doing some sort of dyspnea scale. And this is one of them that you can use. I think on the next slide, I have a CAT assessment as well. Really, they're pretty quick, actually. This one is pretty easy, where the patient can literally just tell you when they get short, how quickly do they get short of breath. It really is just quantifying disability attributable to their dyspnea. But it doesn't, accurately quantify response to any sort of treatment or patient effort. Obviously, if they're not moving around because they get dyspneic and they're so, they're deconditioned and dyspneic, it doesn't capture that. But what's important is that you can use this as a component of the BODE index, and which we'll talk about as well. And it's a calculation that you make that helps you prognosticate, right? It predicts adverse outcomes, including mortality and their risk for hospitalization. So it's important to know about this, and every once in a while ask patients about this, because it'll help you in just quantifying a little bit better, but also using it in giving them an idea of how sick they are. Then the other assessment tool is your CAT assessment tool. I actually use this today with a patient, and what's good about it is you can kind of gauge, progression of their disease and decline in their functional status. So you'll ask them about things like cough, chest tightness, dyspnea, but then also, how they're doing from a neuropsych kind of, or psych kind of thing, how they feel at home, and how their sleep is, because as we'll talk about, sleep disorder breathing is very common and coexists with COPD. So just asking them about their sleep and if they sleep well, and also just, energy levels in general. Oops. So you've all seen this, I'm sure, just different types of radiographic findings of emphysema. So over here we have early stage sensory acinar emphysema. So you can see multiple tiny areas of low attenuation. Here is where it's more advanced. You can see that you could just see that it's more central as well. Then this is panacinar emphysema. So you can see very diffuse low attenuation areas. So different patterns, but you will see this over and over again. All right, very briefly about alpha-1 antitrypsin deficiency, and I know there was a question in the pretest. So as we know, alpha-1 antitrypsin inhibits neutrophil elastase, which prevents, breakdown of the alveolar wall. So 2% of patients with COPD have this, have severe alpha-1 antitrypsin deficiency, and only 10,000 of them are receiving replacement therapy. I think I've only sent one patient so far for replacement therapy, but it's also because I haven't diagnosed that many patients with it. So they develop panlobular emphysema, and of course, you're going to look for it in younger patients with basilar emphysema. They may or may not have a significant smoking history, and they can also, of course, develop liver disease as well with this. Cysts and whatnot. Treatment would be with IV pooled plasma alpha-1 antitrypsin, and it may slow the decline in lung function. So when they do the electrophoresis, in terms of what the genotypes look like and emphysema risk, the ZZ is associated with 80 to 100% essentially emphysema. These tend to be the most severe patients. So that was the answer on the pretest. And also the boards like to ask that as well. So then there's other, classifications. And really it has to do with how quickly there's migration of the gradient across. So A to Z, with Z being the slowest migration, so ZZ, highest risk. Okay, so this is the Bode index that I was talking about, and when you initially see your patients, you would want to calculate this for them, and it allows you to have an idea of what their 4-year survival looks like. And basically it stands for body mass index, degree of obstruction by FEV1, and then the distance they walk during their 6-minute walk test, and their dyspnea, their evidence of dyspnea, so their MMRC dyspnea scale score. And points are based on, so BMI is really just if they're greater than or equal to 21 kilograms of meter squared. So they get either 0 or 1 points. Obviously, the higher the points, the higher their mortality is. We're gonna actually, I think we're gonna do a question next. Yep. So basically, you put this together. I mean, they have these calculators, on MD Calc and all that kind of thing. But it is something good to maybe to incorporate into clinical practice when you're first seeing patients, and to give them a sense of. I mean, you don't have to tell them, your 4-year survival is like, 60%, but just so you have an idea. And it's very important to know that. So we'll just go over a quick question. So 65-year-old female comes to your office following her second acute exacerbation of COPD this year and asks if you could tell her anything about her prognosis. She has no other significant medical problems. Her FEV1 is 30% predicted and improved by 12% and 200 mLs. So she's got a bronchodilator response. Resting O2 sat is 94, and it goes down to 90 at the end of her 6-minute walk test, where she walked 200 meters. BMI is 20, and then she is on triple therapy. And when she's walking on level ground, she needs to stop every few minutes to catch her breath. So which of the following statements is most accurate regarding her prognosis? So just to kind of go through this quickly, so the answer is actually C. Okay, right? Yeah, it's C. So the Bode index, so we're going to talk about the 4 variables. So the fact that her BMI is less than 21 gives her a point. Her FEV1, sorry, because I don't remember, is 30% predicted, right? So that anything below 35% gives her 3 points. Her 6-minute walk test distance earns her 2 points. And her degree of dyspnea falls under grade 3 on the MMRC. So that gives her an additional 2 points. So her total score is 8, and that means that her mortality is 80% at 52 months. So just as an aside, other factors that will increase morbidity and mortality are acute exacerbations, hospitalizations, and of course, if they have cardiac comorbidities. And we're going to go over this again and again, but survival benefit with O2 therapy for chronic hypoxemia, smoking cessation, and lung volume reduction surgery in selected individuals. That was just, addressing what the other answers were proposed. So now another question that I was thinking about is, you see a 55-year-old lady who's a smoker, significant smoker, with symptoms of daily cough and dyspnea on exertion. Her spirometry is normal. CAT scan shows very mild central lobular emphysema. So does this patient have COPD? So it's what I was kind of alluding to earlier as this type of pre-COPD. So basically it's spirometry without obstruction, but have these, they have like an FEV1 that's like maybe on the low end of normal range, and a reduction in FEV1 that exceeds 40 mLs per year, which is higher than the normal rate of loss after your third decade of life of about 25 or less mLs per year over an 18-month period. So meaning that you see these patients, they're symptomatic, their FEV1 is low normal, and you follow them up with repeat spirometry, and you see that they start to have a decline, right? And usually they are current or former cigarette smokers, so they have risk, of course. And it's associated with an increase by a factor of 36 in the risk of COPD that may develop over the next 5 years. Okay. So in terms of management, anyone have questions or anything they want to bring up? Okay. In terms of management, mainstays of therapy, of course, are smoking cessation, having them on the right maintenance medications. If they need supplemental oxygen, start them on it because it improves survival. Mucus clearance, of course, we know about using aerobicas and acapellas. Mucolytics, they talk about it in the guidelines that I sent out, excuse me. I know we don't use Mucomyst as much, but they do say you can use it, and other mucolytics, of course. Considering some sort of sleep study, pulmonary rehab, early referral, and other interventional therapies. So the goals are to reduce symptoms, right? So you want them to feel better, to increase their exercise tolerance so that overall it improves their health status. And then you also want to reduce risk for exacerbation, so prevent disease progressions, prevent and treat exacerbations, and reduce their mortality. All right, so this is really just going over, it's just like a summary of all of that. And once again, it's from the GOLD website. So if you're interested, you can definitely pull it up, or you'll have these slides. So initial pharmacological treatment, they broke it down by GOLD classes. So of course, if you're in group A or group 1A, you start with a bronchodilator, short-acting bronchodilator. So it could be either a beta agonist or a muscarinic antagonist, short-acting, right? So then, depending on whether you, so if you're more symptomatic, of course, you go to a longer-acting bronchodilator. And per the guidelines, they're saying LAMA over LABA, which is fine. Either way, right? They need something long-acting. And these are not, they're different than how asthmatics act. So you can prescribe a long-acting beta agonist alone without, an inhaled corticosteroids in these patients. Now, if they start having more than one exacerbation leading to hospitalization, or they're having greater than or equal to 2 moderate exacerbations, then you want them to definitely be on a long-acting muscarinic antagonist. But if they're highly symptomatic with high CAT score or MMRC score, then you would start to think about combination therapy, so LABA-LAMA, or adding an inhaled corticosteroid. Now, we're going to talk about this and the fact that the way to predict whether their rate of whether you can improve or prevent exacerbations in these highly symptomatic patients who are at risk is by checking serum eosinophils. So here they're saying consider adding an ICS if your eosinophils are greater than or equal to 300 cells per microliter. But I think that I've seen it where you can consider it earlier when their eosinophils are as high as 100. It's kind of like an intermediate zone between 100 and 300. But the point being that if you do check them and they're high and you start them on inhaled corticosteroids, this is predictive of helping prevent further exacerbations. Okay, so here's another question. Actually, there's two questions, right? So one is, what gold group does this patient fall into? And then which therapeutic intervention would be most appropriate for this patient? So 52-year-old comes in for optimization of his COPD. He slows his walking speed because of shortness of breath, but it's not limited in how far he can walk. He was prescribed albuterol a year ago. He uses it twice daily, but he doesn't feel like it really helps. He gets frequent colds that cause chest colds, and he needs antibiotics on 2 occasions in the past 2 years. And he has a 30-pack year smoking history, but stopped 7 years ago. No other significant past medical history. So on room air, he's 96%, and his other vital signs are normal. He has decreased breath sounds, no wheezing or crackling, and no other signs of consolidation. And then you do a chest x-ray. It shows hyperinflation, but nothing else. And then we have his spirometry on the next slide. So basically you see that his FEV1, well, his ratio is reduced, and that his FEV1 is 55, right? So the question was, what gold group does this patient fall into? And then what therapeutic intervention would be most appropriate? So we'll talk about the gold, but does anyone have an idea as to what they would want to do next?
LAMA.
Okay. And you're right. So in terms of, and why did you pick that?
Because he needs some sort of maintenance therapy. He's pretty symptomatic, and he falls into gold group. I think I said B, but it's definitely C. I always get those two confused.
Mm-hmm.
So he needs some sort of maintenance in the LAMA, just some long-acting bronchodilator.
Yeah, a long-acting bronchodilator. Perfect. Yeah. So yeah, so you're totally right, and he does. He falls into group 2B. So he's got moderate airflow obstruction with 55% of predicted. He's been having frequent exacerbations and enough shortness of breath to affect his activity. So he's only on a SABA, so it makes sense to definitely start him on some maintenance therapy with a LAMA. Of course, other things that you would want to do, you know, we know about vaccines, start thinking, I mean, I think it's a little early for pulmonary rehab, but actually, no, that's not true because he is very symptomatic. So it would be something to consider. At least send him for that 6-minute walk test and see, you know, how he does, and then go from there. And then, you know, the guidelines from ACCP and the Canadian Thoracic Society recommend use of LAMA over LABA to prevent moderate to severe exacerbations of COPD. You know, I don't know. I don't know if it really makes a huge difference, which one you use, but that is the recommendation. I don't know if anyone else wants to comment on that, but that's what, you know, that's what you would typically do anyway. And we've gone over this, so I don't think we have to keep going. They bring up in the guidelines, they talk about things like methylxanthines, theophylline. We don't really obviously use that, but just kind of know that it's there. Okay, so main things to kind of take away are that so obviously long-acting muscarinics and LABAs, they'll bronchodilate, and they can reduce the effects of airway remodeling that way. Combination therapy can be as effective as ICS combination agents in increasing your FEV1, improving quality of life, and reducing exacerbations. But like I said, adding the inhaled corticosteroid, how can you predict if it'll help? So you can look at their blood eosinophils, and if there's at least 100 cells per microliter, then you would think it should be helpful, but definitely if it's more than 300. So in terms of triple therapy, triple therapy, so there's 2 that we use, so it's either Trelegy or Bevespi. They also, like I said, improve FEV1, quality of life, and reduce exacerbations. And then, of course, there's always this concern, not as much by us because we love steroids, but, you know, the concern that there's a mild increase in pneumonia incidence and possible weight gain, osteoporosis, but you know, the benefit greatly outweighs the risk of having worse, more exacerbations of your COPD. And then, of course, you know, in the future, and there's a bunch of studies about this, looking at gene expression may be helpful in predicting efficacy, really trying to like genotype, phenotype the different types of COPD and to what therapy that they would be most responsive to. That's in the works, but, you know, we'll go with what we have. So in terms of exacerbations, we obviously want to not, you know, the goal is to minimize the impact of a current exacerbation or to prevent an exacerbation subsequent to the previous one. So acutely, of course, you're treating with short-acting bronchodilators. Steroids, as we know, allow for more rapid recovery, improvement in lung function and hypoxemia, and reduce the risk of having relapse in the next 30 days. Antibiotics, of course, controversial. Up to 50% of exacerbations are associated with the typical pathogens like H. flu, strep pneumon, and Moraxella. And it's unclear if this is from chronic colonization versus a new strain of the infection, and really it's your best judgment. Of course, if they're coughing up more sputum, it's changed in color, then you might, or of course, if they have something, you know, on imaging, then you would want to treat with antibiotics, but you know, that's more controversial, but definitely the steroids and the bronchodilators, we all know this. And we've pretty much already talked about this. You can definitely reference this on the GOLD website, but I think we've already talked about it. And then in terms of anti-inflammatory therapy, so we talked about the inhaled corticosteroids. Long-term use of oral steroids, as we know, can have numerous side effects. Of course, if they need them, you know, during the acute exacerbation, and then you titrate them down, we know those patients who end up on like 5 milligrams of steroids long-term, and they just kind of, they need that for whatever benefit it's providing them, then of course you try to keep them at the lowest dose necessary for them to not exacerbate and go back up on their dosing. The other thing, of course, is if you have patients with symptoms of chronic bronchitis, then you can use PDE4 inhibitors, so roflumilast, Daliresp, that can help improve lung function in these patients, and it reduces moderate and severe exacerbations. That's evidence A. And then the other thing is of course, using low doses of thermycin can reduce exacerbations over 1 year. Excuse me. And then here they talk about mucolytics as well. Evidence B, we don't use it as much, but you know, if the patients feel better with it, then it can potentially reduce the risk of their exacerbations. We just don't use it regularly. And then they had done some studies with statins, and that is not recommended for prevention of exacerbations, of course. So this is an overall, you know, like an overall algorithm of what to do with exacerbations and what to think about. And then this is just maintenance therapy. Okay, so I think we went over this a lot, so we'll keep going. And once again, initiating ICS therapy, blood eosinophils 100 to 300 cells per microliter. Okay, and then we'll just talk a little bit about O2 therapy and OSA COPD overlap and using non-invasive positive pressure ventilation. So gas exchange in COPD. So we know that mild hypoxemia is common. They, over time, can develop more severe hypoxemia, less common, but it has to do with increased VQ mismatch, alveolar hypoventilation, and then, however, shunt and diffusion abnormalities do not typically contribute to hypoxemia and COPD. And then as they get worse, then they can start to develop hypercapnia. So as their dead space ventilation increases, where you have emphysematous regions that are poorly perfused, you start to not be able to ventilate well, and your CO2 goes up with increased work of breathing, and then in alveolar hypoventilation itself in advanced disease. And this can worsen, of course, during severe exacerbations. So we know the indications for O2 therapy. If you're hypoxemic below 88%, of course, if you have a PaO2 of 55 or less than 55, evidence of erythrocytosis. This is like the board stuff that you're supposed to know. But if, on a day-to-day, we know that if their O2 sats are dropping either at rest or with ambulation below 88%, that they need supplemental oxygen, and that improves survival. So 2 landmark studies from back in the 80s, and both of them were the ones that looked at long-term O2 therapy and COPD. And really, this is where the mortality benefit was seen if you administer oxygen for at least 15 hours a day. And it also has been shown to improve quality of life, neuropsych metrics, probably because they're getting more oxygen to their brain, and pulmonary hemodynamics, right, because they're at increased risk for developing pulmonary hypertension. And the rule is that basically you increase their flow rates by about 1 liter per minute when they're exercising and when they're sleeping. Okay, so this is another question. So what's the next most appropriate step in his management? So you have a 63-year-old male. He's a former smoker, 40 pack years, who quit 5 years ago, who's admitted with acute exacerbation of COPD. He required non-invasive ventilation for 24 hours, but responded to in-hospital therapy and got better. He's discharged on day 8 with an appointment to see you in about 3 weeks following discharge. This would never happen in our system because we always see our patients within 7 to 10 days because of the email. And so you're seeing him now 3 weeks later, and he's telling you that he's been getting better and nearly back to normal using his meds, but and that he's scheduled to attend pulmonary rehab next week, which is amazing. So, but he tells you that he becomes short of breath with minimal activity. He's sleeping well, doesn't complain of any other cardiac type symptoms, and he has no other symptoms suggestive of sleep disordered breathing. When you examine him, though, his SATs are 83 on room air at rest. Then you put him on 1 liter and he goes up to 93%. His BMI is on the low side, but his vital signs are otherwise stable. He's got reduced breath sounds, and it doesn't look like he's in heart failure. So his CAT score is 24, so it's high. And then we're going to look at what his pulmonary function testing looks like, and this is his ABG on room air. So he's hypercapnic, compensated, right? But he's also, it's on room air. He's also hypoxemic. So what's the next most appropriate step? So let's just look at this. So, so you could see his FEV1 is very reduced. His total lung capacity is elevated, and his residual volume is pretty high as well. Is high as well, and then his DLCO is severely reduced. So what do you want to do for him? So you're 3 weeks out. Those are his PFTs, these are his symptoms, and his O2 sats. So obviously you're not going to wait for 4 weeks. Are you going to start him? The main thing is do you start him on supplemental O2 only, or do you also start him on non-invasive to reduce his PaCO2? Or do you refer him for lung transplant?
Wouldn't you definitely start him on O2, but don't you not want to start him on non-invasive without study?
So you would want to send him for a sleep study, but I guess the point being, so the answer is actually C, but I think the point being that because of the hypercapnia and because of the chronic hypoxemia, that you would want to start him, you would want to start him on non-invasive as soon as possible. So you'd want to get him into the lab as quickly as possible and start him on non-invasive, because it has been shown that if you do both together in someone who is both hypoxemic and hypercapnic, that it reduces hospital readmission and, well, the composite endpoint of hospital readmission or death within 12 months. They just do better generally. So yeah, this is someone you would have wanted to see if they didn't get discharged with their non-invasive from the hospital. Then you would want to see them in the office pretty quickly thereafter and get them in for a sleep study to get them titrated right away. So just to note that, you know, if you have an acute exacerbation that requires acute non-invasive with persistent hypoxemic and hypercapnic respiratory failure after stabilization, poor prognosis, and median time to readmission or death is less than a year. So you want to be aggressive with them. And you want them to use it for at least 6 hours a night, and of course with oxygen, with the aim of reducing nocturnal hypoventilation.
In a patient like this, where you don't have a sleep study yet, and you obviously want to get one, but you want to start them on a non-invasive, I mean, would you prescribe them like an APAP machine just in the meantime until you can get them in the lab and do maybe a sleep study or something like that?
Right. So that's a good question. So I wouldn't. I would want to see, because they probably should be on bi-level, right? They need that pressure differential, that pressure support to allow them to ventilate better, right? So you're addressing both the hypoxemia and the hypercapnia that way. So I wouldn't. So either they're in the hospital and you're trialing them on, I mean, probably AVAPs, just because you can set it like a ventilator and know what their minute ventilation is going to look like, and then, you know, repeat their blood gas. But then I would just say this is like one of those patients that you want to expedite getting their study done. You could, but in the interim, I would still start them on oxygen, of course, you know, during the day and when they're sleeping. Even though he's hypercapnic, he is compensated. So I think if you address some of that hypoxemia, there's the, you know, the off chance that maybe his hypercapnia will start to improve a tiny bit. But regardless, you're going to get him into the lab as quickly as possible, if that makes sense.
Mm-hmm.
So yeah, so there's a big overlap too. So that was just, you know, patients with COPD who are now so hypoxemic that they're becoming hypercapnic and hypoventilating. Now there's also something called the overlap syndrome, where up to 16% of patients, which is similar to that of the general population, have this overlap. And but we see a lot of sleep-related hypoventilation, sleep disordered breathing in general in COPD in up to 40% of COPD patients. So it's very prevalent. It's more common than a lot of us think. And really, when you have both together, they make each other worse, because you develop more severe hypoxemia every time you obstruct, or you know, even if it's like a central sleep apnea, you have a pause to breathing, you become hypoxemic, but you have no reserve, right? Because your vital capacity is lower and all that kind of thing. So you just don't have as much O2 reserve. And you develop hypercapnia. You're at increased risk for pulmonary hypertension. And then it's associated with other things like poor quality of life, more frequent exacerbations, and increased mortality, actually. So really, we need to be screening all patients for sleep disordered breathing, which generally we do. You know, whether it's, even if it's not an in-lab test and you get a home sleep test and you see that they have significant sleep apnea or they have significant hypoxemia, you want to make sure that you're getting them treated as soon as possible. Okay, we're almost done, I think. Is everyone still there? Are we okay?
Yep.
Okay, cool. So I won't go through the whole thing, but basically the basics of this question are when to start pulmonary rehab. And the whole point is that in someone who is recently in the hospital or has had multiple, you know, exacerbations with, you know, significant severe COPD, that when he's in the hospital, you want to get him into a pulmonary rehab program as soon as possible. I know sometimes when I'm on the consult service, they'll ask, you know, how do I get discharged to pulmonary rehab? And unfortunately, that's not a thing, although it would make sense for a lot of patients who have severe COPD. But really, you want to follow them up and get them referred to pulmonary rehab as soon as possible and not wait. So that's all this is. So it should start during or immediately following hospitalization in an ideal world. Actually, I'm trying to think if there is an inpatient pulmonary rehab, or almost like a subacute that's a pulmonary rehab somewhere in Westchester upstate. I might be making that up. Samir would probably know. We'll ask him. But that's what the whole point is, right? So you want to improve their symptoms and their quality of life. And that's pretty much, it's everything that we've been talking about. Okay, so now we're just going to briefly talk about some interventions. Lung volume reduction surgery, so that is an option in patients who have upper lobe predominant severe emphysema and a low so they go to rehab, but they still have a pretty low exercise capacity. It's been shown to improve survival and quality of life. However, the patients that you would not want to refer for lung volume reduction surgery are patients who have an FEV1 of less than or equal to 20%, a homogeneous distribution, or a very low DLCO. So makes sense, but this is something you have to also know for the boards. But it is one of those things that in the appropriately selected individuals that it does improve their survival. Another option is bronchoscopic lung volume reduction. So basically where they place endobronchial valves into an area of discrete, like emphysematous area of lung, and there's selective collapse of that area, and you improve ventilation. That's all I'm going to really say about it. We haven't really done it that much. I mean, I'm sure Abby can speak to it more so than me, but they are at somewhat increased risk for like developing pneumonias after that and other issues. So I don't know how well it works on a long-term basis. I don't know if it's more of a palliative approach, but I haven't referred anyone for it. And I actually haven't seen anyone who's had it done, but that's me. So there might be someone else that could speak to it. So this was just talking about surgical options and talking about the fact that this patient who has advanced COPD went to pulmonary rehab, has had 2 exacerbations of COPD in the past 6 months. His FEV1 is 18%, right? And he's had homogeneous distribution of his emphysema. So this is not someone that you would want to send for LVRS. You actually would want to send them for lung transplant. And that's the answer to that. And really, in terms of guidelines for that, FEV1 less than 25% predicted, hypercapnia, hypoxemia, or a BODE index of 5 to 6. And this is just kind of an overview of what the guidelines recommend. So let's see if there's anything else I have to tell you. And this is just an overview again. So these are the pretest questions. So basically, how can you predict if adding an ICS to LAMA-LABA, I think it was LAMA-LABA, but anyway, how can you predict if adding an inhaled corticosteroid will reduce the frequency of exacerbations? And we already said high blood eosinophils. And then in terms of alpha-1 antitrypsin phenotype, with the highest risk of developing emphysema, it's going to be ZZ. And a lot of us know ZZ, so now the person, so I think we'll all remember that. We already went over this one with the GOLD classification. This was the grade 2B patient, so we don't have to go through that again. And this is just, review of that chart that I showed you guys earlier that's on the GOLD guidelines. And actually, I think we're done. I mean, this is really just like the prevalence of undiagnosed COPD. This was just something I came across, but it's actually pretty high. I was pretty surprised by it. The answer was 70 to 78%. And this is in a general population in patients who have smoked at least 10 pack years. So, screening for it on a primary care basis. But of course, any patient we see, we're going to ask them about their symptoms. So these are the take-home points. I think we went over them in detail, but really things that, we need to keep in mind. Something that's really important is just think about the way I think about exacerbations is that they're bad and that they are to COPD patients what acute MIs are to cardiac patients. So they make your disease worse and they increase your mortality. And then in terms of reducing exacerbations, you have your inhaled corticosteroids, LAMA, LABAs, macrolides, and early pulmonary rehab. For survival, it's really just oxygen therapy, smoking cessation, and lung volume reductive surgery in selected patients. And we should all, at least try to ask patients about their symptoms regularly. When we see them, use one of these symptom scoring tools and, put them into a goal classification and then prognosticate using the Bode index. And that's it.
That was great.